So let's go through some of the various approaches that I've got listed. And let's see if they work, don't work. What's your experience? Value-based plans that focus on overall balance of benefits to patients, physicians, and the plan at large. Does that make sense? Does that work? Anybody got experience with that?
Well, some employers, especially large employers, who are focused on the long term because they're going to have these employees to retirement, if you will. So they're very focused. We mentioned whose risk is it? And when you think long term, and in accountable care, you're also forced to think long term. Elements around prevention and wellness resonate quite well. So incentives that are built around filling out of going even beyond process and health risk appraisals, but even linking benefit designs to a value-based system. The other is we're seeing also disincentives, where some employers are saying, and from health fairs, you can identify population-based risk, and if you're not moving toward ideal biometrics, the disincentive is your premiums increase. But there's other, efforts around, working with providers, sharing data, profiling, identifying gaps in care. Nobody gets up in the morning wanting to do a bad job. But how can we help providers be more
I'm sure
efficient?
somebody gets up in the morning.
How can we help providers, do a better job in terms of identifying patients that truly have gaps? And then, to Jeff's point earlier, how can we stop duplicating but actually work in team effort to do the outreach for members? And also get the information back to physicians so that they understand where they are in terms of their quality measures and how can we.
How about this one? Provider-focused approaches. That is to say, pay for performance. If your patients aren't getting their A1Cs down, they're not losing weight, we're not going to pay you as much. Providers, does that work?
Well, it should work. It may work in some areas, but on the other hand, it may lead to the fact that I will not accept some of the tougher to control type 1 patients, because I know that tougher to control, I will not touch an adolescent guy with type 1 diabetes, because there's no way I can get them into pay for performance. So we've got some issues with that. A lot of
exclude a whole patient group.
It may do that. Actually,
There's also ways those are set up. I mean, there's incentive and the carrot versus a stick, incentive versus disincentive. So I think most P for P is incentive-based.
it's going to run out there, and it's going now to become...
But if it's a zero-sum thing, somebody's going to lose, somebody's going to win, right? I mean, the surgeons went through this when their results were published, and there were lots of surgeons who wouldn't touch very sick people with heart disease, wouldn't do bypasses on them because they had a higher risk of dying.
My hospital had the best rate of surviving heart surgery because of the type patient that the surgeon did choose, and he had like a less 0.3 mortality, so everybody wanted to be cut by him, but turns out he would not take anything complicated.